Thanks, Michael, and thanks to Jim and for SIG for putting on such a great program and inviting me to speak. Obviously, this is a massive topic, and in 15 minutes we'll just sort of scratch the surface, but hopefully it'll gender some nice discussion afterwards. So I'd like to show this slide. It kind of gets to what is the logic behind spinal deformity. And if life in gravity correlates with poor sagittal balance and pelvic compensation, then we can conclude that life is a kyphosing event, and I credit Isaac Newton for that. And then Steve Glassman, I think we can credit for correlating poor sagittal balance with pain and disability. And then we can credit Frank Schwab for showing us how pelvic compensation correlates with increasing pain and disability. And if we take those three tenets, then the conclusion is pretty clear that the longer we live, the more we're going to hurt. So the bottom line is, enjoy it while you can. Well, there's really two main issues here. We got to really identify the best and most reasonable candidates for deformity surgery, and we kind of need to achieve spinal balance. We need to figure out how to get patients into this cone of equilibrium, and I think it's a fantastic concept. Think about that a lot. We don't want to operate on people that have a pannus that kind of goes below the park bench. So patient selection becomes key. We need to identify the location and the pattern. Is it back pain predominant? Is it leg pain predominant? Is it mechanical and relieved by rest, or is it there just all the time? Is it pain at the apex, or is it some other place? And if it's radicular, and this gets to the conversation we had before, is it monoradicular? Can you isolate the one specific nerve root? Can you do that with a selective nerve root block? Is it an EMG, or is it just based on a good physical exam? Can you reproduce it with side bending? I think that's an important test to use in the clinic, especially looking at 5-1 foraminal stenosis. With flat back, they have to fit the classic syndrome of flat back. It's usually lower lumbar. They get easy fatigue with standing. They get great relief with either sitting or leaning forward, and they become more bent over the course of the day. You just ask them at the end of the day, are you more bent forward? Oh, I can't wait to lean at the end of the day or lie down. We need to look at the demographics. What's their age? What's their physiologic age? If they're over 75, for me, that's when I start to think a little bit about, do I really want to expose this patient to a major operation? And somewhat ironically, older patients will do better because they come to surgery with a higher level of disability. We need to look at their major comorbidities, and SIG did a nice job of looking at this in one of the first talks, and looking at bone health. Osteoporosis, we know, is a major risk factor. It really should be less than 2.5, and we should be checking pretty much anyone who we're thinking about doing a big operation. Nicotine, alcohol use, and BMI. The psychosocial history is crucial. What's the depression status, and are they being treated? And what's their employment status? Can they realistically go back to work? And what do they hope to gain by going back to work? What's their marital status and home support? This is crucial. The first month after surgery is a big deal for these patients. And of course, we've discussed this a lot today, is setting realistic expectations. We know the complication rate is extraordinarily high. PJK risk up to 40%, and revision surgery is incredibly expensive. And then are we checking self-reported outcomes on everybody? Well, the frailty index, this we're seeing more and more of. I find it pretty hard to use in my practice because it's 40 items, and you have to be really thorough. It takes a lot of time to go through this. I think it's great for research, but for routine, practical use, it's tough to incorporate. I used this slide last year, and it got a nice response, so I put it up here again. This is the Union Memorial, which is the hospital where I work. This is our resident index. It hasn't been validated against the frailty index, but these are poor prognostic signs for surgery. Number 1, hyphenated last name. Number 2, more allergies to medications than medications. Also, if you have an allergy to more than 2 opioids, if you work for Social Security, or an adult patient comes to the hospital with a stuffed animal. If your hair is copper colored, whether you're male or female, Women in hats raises an eyebrow. And if you are dressed in an attire that's a different ethnicity from what you are, sunglasses indoors, fibromyalgia, hairstylists and flight attendants, especially if they're together, injuries caused by video games, horse people in general, high pain tolerance patients. And if you have pain greater than 10 when you come in and you have a high pain tolerance, that's really bad. And then combinations of any of the above. Well, the physical exam, I think, is often not taught, and often we don't pay as much attention to it as we probably could. So with the coronal issues, is it a flexible coronal deformity? And side bending in the office as well as on x-rays is important. Is it passively correctable? So I actually like to lift up under patients, under their arms, to see if I can passively correct their spine. And using your hands on the apex with a 3-point bend. Can you flex their curve? And where is it? With sagittal patients, is it a fixed deformity? They have ankylosing spondylitis. Have they had previous surgery? And I like to get a bolster x-ray, a lumbar extension lateral. Is it compensated? Do they have pelvic retroversion? Are the knees and hips flexed? Is it a fixed contracture? Is their scapula extended back to hold them up against gravity? And then where's the location? So this is an interesting patient who came in. I had him stand. You can see his arms are anterior to the greater trochanter, which is a sign of imbalance. But you can see I asked him to extend back, and he's really not extending through his lumbar spine at all. And you can see how forward he is. And here I'm looking at the back. He's extending and he's bringing scapula together, but the lumbar spine isn't extending. And his MRI shows that he's quite stenotic in the lumbar spine. Here's his sagittal x-ray, so he's way positive, 14 centimeters positive. But we decided just to do a focal decompression at 4-5, where he's the most stenotic, and we didn't get him all the way back, but he's pretty straight now, not hyperextending, and he's relaxed posture and standing. So let's go through the radiographic evaluation. The full-length PA and lateral full cassette is key. Knees and hips have to be fully extended to get this done properly, and arms are crossed and placed over the clavicle. There should be no external support. And then for the coronal plane, we get the cob of all of the curves. We look for lateral aesthesis, and I like to measure that, especially if I'm following patients over a period of time. And we look at their C7 plumb line. On the sagittal plane, it's their thoracic kyphosis, which is T4 to 12, their thoracolumbar kyphosis 10 to 2, and then their lumbar lordosis L1 to S1. And our residents often think of thoracic kyphosis as T1 to T12, so important to make that distinction. And then for the sagittal plane analysis, looking globally, the SVA and the TPA, T1 pelvic angle, and the sacral vertical axis, remember, normal is less than 4 centimeters, and for the T1 pelvic axis, less than 10. And then the spinal pelvic parameters are really crucial. We want the pelvic tilt to be less than 20, and we want the PI minus lumbar lordosis to be less than 10. That's pelvic incidence minus lumbar lordosis less than 10. So putting all of this data together, and I really credit Frank and the SRS, Dr. Schwab, that is, for 15 years of review of thousands and thousands of patients and correlating their radiographs to their clinical parameters, really brought us to this modern SRS Schwab classification system. And the 4 coronal curves on the left are really to categorize where the deformity is, but it's really the 3 sagittal modifiers that correlate with pain and dysfunction. So the PI minus lumbar lordosis, we want it less than 10. And you get the positive or positive if it's much greater than that. Global alignment for an SVA less than 4, and then greater than 9.5 is the double positive. And then pelvic tilt, you really want less than 20, and it goes up from there. So this is a really important slide. I have our residents and fellows keep a laminate of this in their pockets, so when they're looking at patients, they can just refer to it. And it's crucial now that we temper our correction with age. So this is an important study looking at age-based thresholds for where we stand as we get older. And if you look at the T1 pelvic angle, as we mature, it goes from 10 all the way up to 27.8. So we all lean over time. And if you look at the pelvic tilt, over the age of 55, we're all more forward than we consider normal. So when we're correcting patients, we have to bear this in mind. Look at the SVA. If you're over 74 years old, your SVA is 8 centimeters. And then PI minus lumbar lordosis is 13 degrees, almost 14 degrees over the age of 70. So what about the coronal plane? We don't talk that much about the coronal plane since the classification system came out. There's not a whole lot of data on the coronal plane. So I look at these 4 key things. Number 1, the fractional curve, the lumbosacral curve, because that causes, sorry about that, let's go back. Because that can cause foraminal stenosis, the degree of lateral aesthesis, usually at 2-3 or 3-4, and then coronal imbalance. In my practice, it's rare to see it over 4 centimeters, so I start to think about, is there a neuromuscular issue? Is this a Parkinson's patient? Is there something not diagnosed? And then selecting levels. So upper instrumented vertebra should be above the apex. I look for the stable vertebra and the neutral vertebra, and also a vertebra that's level or less than 5 degrees of out of alignment in that coronal plane. So what about the fractional curve? Here's a patient of mine. He's a 60-year-old guy who had really isolated L5 radiculopathy. He had a really severe asymmetric disc collapse at 5-1. You can see a little bit of a lateral aesthesis at 4-5 and 3-4. And again, who wants a big operation? He wanted something smaller. This is sagittal view on the left of his foramen. He had side bending, classic L5 radicular pain. So we just did a 3-level anterior. I was debating doing just a 2-level, but the lateral aesthesis at 3-4 may be a little bit nervous. And he's a year out. He's solidly fused. He's happy. What about lateral aesthesis at 2-3 and 3-4? This tends to correlate with radiculopathy or neurogenic claudication. Here's a patient at a previous fusion. She's almost 50% displaced and had really severe stenosis. And I'll come back to her later when you have some time. Here's a patient who actually had 10 centimeters of truncal imbalance with a serious trunk shift and a fractional curve that brought him over. He is having a lot of standing pain and flat back type syndrome. And then the coronal considerations in selecting the upper instrumented vertebra. It should be above the apex, stable and neutral, and less than 5 degrees of tilt. So here's the patient I just showed before. Here he was postoperatively after a back front back. He's still about 3 centimeters to the side, but he's happy and well aligned in the sagittal plane as well. And then be watchful for the non-structural coronal deformity. So this curve doesn't really fit our classic adolescent idiopathic of adulthood, nor does it fit our degenerative pattern. So he's got a lateral aesthesis, analesthesis at 3-4. He's quite stenotic at that level. And you can see the alignment issues there, 5 centimeters off to the side. And then we just did a simple PARS technique, and you can see how just alleviating the stenosis allows them to be aligned. So an antalgic type of curve. Well, here's that case that I was going to come back to when we have a little bit of time, so I'll go through this briefly. 71-year-old female, quite a host of medical problems, and dramatic sagittal plane imbalance, previous 3 to 5 fusion, but no tobacco, no alcohol, and she was thin, which is always nice, and a normal neurologic exam. You can see her sagittal profile here. And then her coronal plane, she's almost 4 centimeters to the side. Her cob is 42 degrees from T12 to L2. And she's got this fractional curve here, 19 degrees. And then the lateral aesthesis we talked about, I showed you this before, almost 2 centimeters in a sort of a trapped L2 vertebra. So she'd be an SRS Schwab L or lumbar curve pattern. Regionally, thoracic kyphosis was 20 degrees. Her SVA is really positive at 14, and her T1 pelvic angle was 60 degrees or so. And then her spinal pelvic parameters, her pelvic tilt was 30 degrees, lumbar lordosis 11 degrees with a pelvic incidence of 73 degrees, and way mismatched on her incidence to lumbar lordosis. So what were our needs here? She was positive in every modifier, double positive in every modifier. So if we look at our PI minus LL, we needed about 52 degrees of improvement there. T1 pelvic angle, we needed about 31 degrees of improvement. And for our SVA, we needed about 30 degrees of improvement. So that, if you kind of mean those, about a 40-degree lumbar lordosis improvement. So our plan was back, front, back, removal of the screws and osteotomies, using hyperlordotic cages at 3, 4, and 5, 1. She was solid at 4, 5. To spend the time to take that down didn't make sense. And then we got a standing assessment in between that first stage, and then it allowed me to sort of dial in what we needed to do in the back on really what was the third stage. And then we did a T10 to pelvis. So here she was standing, apologize for the bad reproduction, but this was after her osteotomies in the back and also after her hyperlordotic cages in the front. And she's still positive, but she's somewhat improved. And I like doing this and staging it 4 to 5 days in between so I can see how much more I need to get. And then this is an intraoperative table picture. So it's a lateral intraoperatively with the table hyperflexed, and she's about 46 degrees of lordosis there. So we knew we were close to getting where we wanted her to be. So here are the results. Her SVA came down to 0, kind of overcorrected her on her SVA. Her lumbar lordosis got to 62 degrees, and her mismatch was much better. T1 pelvic angle and pelvic tilt still a little bit high, but she's balanced. I've seen her now at her 1-year follow-up, and she's been relatively satisfied. Here she is on her PA. So optimizing outcomes really comes down to an honest assessment of what you think you can do and what the patient is, what their patient's expectations are. Is it leg pain versus back pain? What sort of residual disability are they going to have? Are they truly going to be satisfied with the amount of stiffness they have after a major operation? And are there major red flags like frailty and Sig mentioned the predictive modeling? You wonder if down the line we're just going to be putting these factors into a computer, or insurance companies are going to be telling us what we can or can't operate on. Here's a patient who had osteoporosis, and I did a long segment fusion, and she fell over on the top and ultimately ended up having a C2 to pelvis. And then finally, in the coronal plane, I like to be strategic. Look at the area of foraminal stenosis. Can you select a smaller operation to deal with those issues? With the lateral aesthesis issue, what's the best way to get at that? Be careful about antalgic curves. And for the sagittal plane, we really got to plan carefully with using age-dependent correction norms and protecting the junctions. Thank you.